a brief of everything, but basically it's on electrosurgery, because most of the times we are using electrosurgery, and I still feel that's going to be the future. So we need to know a lot about that. So electrosurgery by definition is the use of radio frequency alternating current to raise cellular temperature as a way to vaporize or coagulate tissue. So when you see this, there are what does this mean? It looks like Greek and Latin, but basically if you break up this thing, you have radio frequency alternating current. So first you have to understand what is alternating current. Then you must understand what is radio frequency. Then you should know why does this radio frequency alternating current raise cellular temperature, and if it raises the cellular temperature, when does it vaporize and when does it coagulate. So the whole lecture is about this. Okay, the definition. We are only explaining the definition. Now we all call this as cautery. The cautery is a layman's term. We've been using this very commonly when we want to use electrosurgery. But actually cautery is a term that has come from a Greek term called koter ion, which means hot iron, and it means destruction or denaturation of tissue by passive transfer of heat or application of a caustic substance. So it is like you want to throw acid on something and burn it, that is caustic substance. So we normally use silver nitrate sticks to burn granulation tissue. We use copper sulfate crystals to cauterize granulation tissue. That is cautery. When you have a wart, a dermatologist takes a red hot iron loop and then he burns the wart, and that is cautery. But then you don't have anything hot, you don't have anything which has chemical energy in it, and you are not directly applying these things on tissues when you are doing surgery. So what you are doing in surgery is not cautery. It is totally different from cautery. It is electrosurgery, and we will discuss about that as we go by. Now, so electrosurgery means you are applying electrical energy, and through using electrical energy you are doing a operation. So electrosurgery it is called. But then what does electricity do to a human body or a human being? We have something called an electrolytic effect. So electrolytic effect is, so you've seen somebody electrician going up an electrical pole and then holding the wire, and then suddenly the electricity comes and he is dead. I mean, these things have happened. Many people have put their finger in a plug point and then got an electric shock, and then they have had a cardiac arrest. So these are electrolytic effects. So this happens when you have a direct current. So direct current is what comes in the electrical lines, and then it also can happen in a low frequency alternating current. So we will try to explain what is alternating current and how it changes different from direct current. We also have something as called a Faradic effect, and this Faradic effect is seen in high frequency alternating current of up to 20,000 hertz. So what is the electricity that is coming in our electrical wire being supplied to us by the electricity board? It is 50 to 60 hertz alternating current. So this 50 to 60 hertz is 50 to 60 times the current moves to and fro inside the wire. So that is what is being supplied to us, but that has to be increased to 20,000 times. From 50 you are making it 20,000 times, and when you do that you have something called Faradic effect, and we have equipment called Faradic stimulator. Have you heard of it? Physiotherapists use it. Where do they use it? Hmm? Nerve stimulator, muscle stimulator. Erb's palsy, you all know what it is. Where do you get Erb's palsy? Shoulder dystocia. Hmm. So what happens? There is a neuropraxia. The nerve is stretched and then the nerve is paralyzed. So there you want to stimulate the nerve and you want to make it work. So you are basically muscular stimulation. So that happens when you have an electricity of up to 20,000 hertz. But this is not what we want. We want something called thermal effect. It has to cut and coagulate tissues, meaning it has to burn some cells and some tissues, and that happens when you use a high frequency alternating current up to 300,000 hertz. Kilohertz is 1000 hertz. So 300,000 is 3 lakh hertz. So the electricity you are getting at 50 hertz is converted to 3 lakhs, and that is what gives you the effect to perform surgery. Okay. So this is a analogy called Odell's water tower analogy. So we are using this to understand different aspects of electricity. So supposing there is water in a water tower, that you can take it as electricity that is coming in an electrical wire and showing its effect, what is happening. So you can have wire pipes which are of different diameters. You can have the water tower at different heights. It can be at a much higher level or it can be at a lower level, and all these will affect the amount of water that is coming out of the tank. So each one has a physical property which changes the effect. So what comes out is the power. The amount of water that comes out is power. The pipe is what is giving the resistance to flow. So the thinner the pipe, the less the water. The higher the water tower, the more the water that is coming. So the height of the water tower is the voltage that you are applying. The thinner the wire, the thinner it is, the more the resistance it is giving to electrical supply. So to explain this much better, we have another analogy. So here you see this is the electricity that is passing. So always it has to form a circuit, electricity, otherwise it will not pass. So it should form a complete circuit and then get back. If you are wearing chappals, you don't get electrified. Only when you don't wear chappals and the electricity goes to earth, it forms a circuit, then you get an electricity. So direct current is something that is flowing in one direction. So we've heard in high school that electrons pass in one direction and electricity passes in another direction. So direct current is a unidirectional current. Alternating current is something that passes on one direction for a moment and it passes on to the other side direction in another moment. So the voltage is the pressure with which the water is coming. So the higher the water tower, the more the voltage. The resistance is offered by the pipe that the flow is coming, and that is the thinner the pipe, the less the water that is coming. The bigger the pipe, the more it is coming. So what I want to tell you is these are the definitions. Current is a measure of electron movement past a given point in a circuit. So it is always moving, the current is moving. Voltage is the pressure with which electrons are pushed to the tissue. So you want a deeper coagulation. Supposing there is a huge vascular area and you are only getting electricity, the diathermy effect at a particular point, but it is not penetrating to the extent you want the diathermy to work, then you have to increase the voltage. The more the voltage, the more it will push the electricity to deeper tissues, and the resistance is offered by the tissue. So, the diathermy effect is different on skin, different on fat, different on fascia, different on muscle, different on peritoneum and viscera. Now, supposing you take a knife in your hand and start cutting tissues, the knife takes a lot of effort to cut the skin. It goes in very easily through the fat, but you have to put in more effort to get into the rectus sheath or the aponeurosis, a little lesser effect into the muscle, and a little more effect on the peritoneum. But then if you have an electrical pencil, the cautery pencil or a diathermy pencil in your hand, skin cuts very easily. The fat doesn't cut. It takes a lot of energy. You have to move it to and fro. And then the aponeurosis cuts easily. The muscle doesn't cut. It keeps twitching and you have to spend a little effort cutting the muscle. Peritoneum cuts easily. What does that mean? Physical resistance has nothing to do with electrical resistance. So, electrical resistance is a completely different property, and that you need to understand. When you use it on different tissues, you can reduce the power if it is something that has that does not have much resistance. If you are using it on fat, you have to increase the energy. How do you increase? Every time you don't go to the diathermy machine, all that you do is you hold the instrument there for a little longer time and allow the fat to burn. See, yesterday you saw me using it in the hernia, a subcutaneous plane. So, whenever there was fat, we held it for a little longer and it would burn. When you had areolar tissue, it would just go like that. So, that shows that the resistance is different and the amount of energy it takes is different. So, power is the capacity to do work in unit time of work. Now, let us come to the diathermy machine. One of the first machines that came was so bulky, it was occupying a whole room. And then they started making machines smaller and smaller, and today you have such beautiful machines. But what do these machines do? Basically, they convert this 50 or 60 cycles per second alternating current into high voltage, high frequency energy. So, you are getting a 220 voltage, it is made to go up to 3500 volts, okay, and then it also increases the frequency to 5 lakh hertz to 30 lakh hertz. In my previous slides, I told you thermal effect. Thermal effect comes at what frequency? 300,000. So, now when it is more than 500,000, it is 100% only thermal effect. You do not have neuromuscular stimulation, you do not have electrolytic effect, it is only thermal effect. So, patient does not have twitching, patient does not die out of cardiac arrest. Okay. So, other thing that you want to do is you want to produce a variety of waves with different wave patterns. We will come to that later. We have cutting energy, we have blended energy, we have coagulation energy. When you want to block a blood vessel, then you use coagulation or desiccation. When you just want to cut a skin, you are using cutting energy. When you have something that is like a muscle which has vessels in it, and it also it needs to be cut, and at the same time it should not bleed, then you use blended. So, you have all different types of permutations and combinations of cutting and coagulation that you use based on the vascularity of tissue that you are performing surgery on. I do not want to go too deep into history. because we have the great historian sitting with us. So it all started in the 16th century, how that people started coming to know about electricity, and then it can affect life and it can affect human body. But then we started getting high frequency AC only in 1890s, and in 1908 somebody was able to develop an equipment that could give us high frequency generation of electricity. But then that was a huge machine which would occupy this room. Then this Bowie was a physicist who sat with a neurosurgeon, and then he did a lot of experiments and found out how to use it on a human body. And he brought out this new technology called spark gap technology, which made the whole machine come into a small box. And the first ever machine that came into use for electrosurgery was Bowie. It was a company by Bowie. He had patented that technology. And anybody who has come from US, you talk to them, they say, give me Bowie. They don't say, give me Datherme, give me Cautery. They'll say, give me Bowie, because Bowie is the machine that was there for ages together. For many decades, that was the only machine. So they've been calling it Bowie. And even after that came, we did not have proper non-flammable gases. All anesthesia that we were using, whether chloroform, ether, were all flammable. Only later on we started having halothane and other things which were less flammable, and that was when we could use it in an operation theatre safely without causing an explosion in the operation theatre. Now, this is a very important slide. So, basically I told you one particular thing about electrosurgery. Electricity can pass only if it can return. It has to form a circuit. So, if you are wearing chappals, it does not pass through you. If you are not wearing chappals, it can pass through you and go to earth, and you get an electric shock. Okay? So, there are two ways of forming a circuit. One is you have a machine there. From the machine you want to deliver the electricity to the patient. So, you can have a unipolar or a monopolar. One wire that is bringing the electricity, but then there should be another wire that takes it back. And for that you are using a patient plate. The patient plate is also called a return electrode. Okay? So, it is returning back to the patient, and that way you form a circuit. In a bipolar, you don't need a return electrode. The instrument itself is like a forceps. So, in the forceps you have electrical energy coming through one, and then it goes back through the other one. Now, let us look at what happens in monopolar diathermy. In monopolar diathermy, why doesn't patient have burns here? Why does the electrical effect happen only here? Any idea? Because it's concentrated there. The whole energy is concentrated at one particular point. It's a very sharp point. But when it comes to a return electrode, it's all diffuse. So, a diffuse thing is not causing a thermal effect anywhere near the return electrode. And even in the body, when it gets into the body, it's all spread all over the body. So, there is no focus, and so you don't have any burn anywhere. You have a lens in your hand, and then when we were all children, we would play, we would focus the sunlight onto a dry leaf or something, and then we would see it burn, or a paper. And so, only when you focus things, you see it can really cause very good thermal effect. So, that is what happens here. But then what you need to understand is, it does not have artificial intelligence or natural intelligence. It does not know that it has come from the machine. It has to go back to the machine. It will try to find any place to go back electricity once it comes to the patient. So it can go through a drip stand if the drip stand is touching the patient. It can go through any small point, leggings. The leggings are touching the patient, through the leggings it can go out through the OT table and go to the earth. So it need not go back to the machine. So what happens again when the drip stand is touching, again you are allowing all the energy to focus at one narrow point. When you are having the leggings, again it's one single rod and there is a very small area touching, and so it is focusing, and so you can have burns in these areas, and that is the reason you should not allow any metals to be touching a patient. Now, why do you want the nose ring to be removed? Why do you want a necklace to be removed? Why do you want a bangle to be removed? Hmm? As it is, nothing is happening, but supposing something else touches the bangle or the nose ring and it forms a circuit and gets out, it exits through that area, again it is going to be a very thin area, very small area, and it can cause burns. And that is the reason you don't want these metals, any metal to be touching the patient. Okay. Now this is bipolar. As I said, bipolar, what happens in the bipolar? You have energy going to the patient through one of the electrodes. This is like a loop. You can have a bipolar loop, you can have a forceps, you can have a grasper. It is not like a hook wave, it is not a single instrument. There are two metals which are together and it is coming through one and it is going through the other, and these two are not touching each other. Inside there is insulation between the two. Even when you have a grasper to catch tissues to like a Maryland for a grasper, you have insulation between them in the joint. So next time you go to the operation theatre, just observe a regular instrument like a grasper or a scissors or a Maryland and a bipolar coagulation forceps. There is insulation in the bipolar coagulation forceps. So this two arms of the limb, two limbs of the instrument are not touching each other anywhere other than it can only go to the tip, go to the tissue and then come back. So here what is happening? You are not allowing energy to go into the body, go unscathed, try to find an exit, find something else and then go exit. No, it is just there, it goes only to the tissue which you are holding. So it is pretty safe. Okay. And secondly, you don't need a patient plate. So every time you are using a bipolar diathermy, don't ask if you are using only bipolar diathermy, you don't have to put a patient plate for the patient. Only when you are using monopolar, a patient plate is required. Okay. Now let us look at what are the advantages and disadvantages of the two energies. So monopolar diathermy, it is very easy to use. It does both cutting and coagulation, and because it does both, it can dissect. See, now there was bleeding, you cut with a grasper and then you touch the thing, you can cause coagulation, you can dissect out. So you can do everything with this. So that's a neat job with a simple dissection, and it is easier to use. But then what happens? The disadvantage is that a large volume of tissue can be injured. It can. So what happens if by chance I have not regulated the amount of electricity coming, the voltage and the current, suddenly I can have a gush of electricity, and so instead of burning a little, it can burn at least 1 centimeter or 2 centimeters all around where I am touching it. So there is a danger of it going as much as possible into any area around it, and there is no control, and this is more important. Today almost everybody, I mean so many people have pacemakers in them. Earlier it was one fellow would have, he would go all over the world saying I have a pacemaker in me. So today that doesn't happen. So you have to ask every patient in your questionnaire before surgery, You have to find out whether patient has a pacemaker or not. If a patient has pacemaker, you cannot be using monopolar diathermy in these patients. Okay, and then you always have to apply a patient plate. Now come to a bipolar diathermy. A small volume of tissue is injured, less risk of burn injury, safe with pacemakers. In pacemakers you can use the bipolar and effective in wet fields. See, supposing wet fields means what? You have not made tissues wet. Tissues are wet. When are they wet? Inflammation. Bleed also. So there is oozing and there is blood on the tissue, and then you are trying to coagulate. It doesn't coagulate very well. You have to suck or you have to wipe and then coagulate it when you are using monopolar. But then in bipolar, even if there is a little blood there, you can still coagulate it. Even there is a pool of blood, you put your bipolar inside it and then coagulating, it will still coagulate. When there is inflammation, that is the most important thing. Supposing you go in after 4 or 5 days after inflammation, whether it is cholecystectomy, whether it is appendicectomy, whether it is twisted ovarian cyst which has got untwisted, whatever it is, there is a lot of edema, and the edema would have increased a lot in 4 to 5 days. First day, second day not much, later on it is much more, and that is when you see there is bleeding when you use monopolar. When you use bipolar, you don't have bleeding. So always remember, you are operating on an inflamed tissue, you are using monopolar diathermy, there is bleeding, you are not able to control. It is bleeding more. Every time you apply monopolar, it bleeds more. Immediately change over to bipolar and you can stop it. So this you must remember.
This applies to vasopressin what we inject into the tissue.
Which one?
Vasopressin we inject before hysterectomy. So that will be also.
Yes, but vasopressin has removed all the blood. So you are not getting. Only when you have bleeding, you are talking about not using monopolar, and monopolar is not controlling it, then you have to go for bipolar. It will still work, but it doesn't work as well. Now, tissue effects in radiofrequency current. So there are basically 3 different effects that happen. One is cutting, another is coagulating, another is just superficial coagulation. You have a liver bed, you removed the gallbladder, it is all bleeding. You don't want to desiccate it like an artery, or you are catching an omentum, or you are catching some vascular structure and crushing it and then cauterizing it to nicely stop. No, you are not doing that. You don't want the liver to get damaged, but only the upper surface of oozing you want to stop. It can be after a pelvic malignancy, you removed a pelvic tumor and then you see an oozing surface. So that is when you want fulguration. Superficial coagulation is called fulguration, deeper coagulation is called desiccation, cutting is called vaporization. And why do you call it? I will tell you later. Okay. So one thing that you have to remember is vaporization and fulguration are non-contact procedures. Now you have a tissue here. So this is a wide electrode. This is a wide electrode. You bring it very close, and as I said, it is non-contact. It's not coming in contact. So that will only coagulate the surface for fulguration. But the same thing, you press on the tissue, you have deeper coagulation. A big area is coagulated. Okay. So based on what you want to coagulate, you have to use it that way. You want only the surface, you don't want the deeper liver to get burnt. So don't touch it, come 1 millimeter away from the tissue, and use it. But if you have a big vessel in the liver bed, venous sinus is there and it is bleeding, then you press on it and then coagulate, then a deeper zone will engulf the blood vessel that is there and it will stop the bleeding. Okay. So basically we have three things that we want. We want cutting. When you want cutting, you must use a sharp electrode and then you should not touch it. Then you get pure cutting without any charring of tissue. You want fulguration, you come very close to it, you don't, no, this is fulguration. This is a wide electrode like a spatula or a ball electrode, but you don't touch it, then you have very superficial coagulation. You want a deeper coagulation or desiccation, you take a wide surface electrode and press on the tissue and then you get desiccation. So now there is something wrong with that. So different things. Now you have you want to coagulate and cut over there. So this is the UV fold you are using. You are using the sharp of the spatula, and when you are using the sharp of the spatula, it is cutting. You see, it's a very thin area. You are hardly in contact with it. You are not pressing it over there, and then there is cutting. But then when you have bleeding, you press the spatula on the bleeding, and that is when you have fulguration and desiccation. Now, what are the other ways tissues are affected? There are variables. One is the generator output, the other is the power density, the other is electrode tissue proximity, tissue impedance, electrode speed time on tissue, and distension media. So, what is generator output? You can have a 250 watt, you have a 400 watt machine. So, the greater the bigger the machine, the more precise that you are using it, and you are delivering it very well, and the voltage that you can use will be much more. So, you have machines which have 400 volts, 300 volts, 250 volts. So, based on that, the performance of the machine changes. Now, supposing you have a music system at home, you have 10,000 watts machine, but you have it in your room, you are playing it very softly. Why do you need a 10,000? You can have a 50 watts speaker, but then the precision of music is so beautiful in a 10,000 watt machine. Even if the volume is not more, you kept it less, but then when you have a speaker with huge wattage, you can very clearly listen to music. You will enjoy it much better than the lower voltage. What I am trying to say is, just because you have a 400 watt electrosurgery machine doesn't mean that you are using 400 watts on that UV fold, but you are doing a much precise cutting. Okay. So, when you are buying, the higher the voltage machine you are buying, the better it is. Now, power density, size and shape of electrodes, we discussed it. How much you press, how much you don't press, proximity of the tissue. Tissue impedance, again we've gone through the resistance of tissues, whether it's fascia, whether it is fat, whether it is peritoneum. And what we didn't talk about is electrode speed and time of tissue. See, in open surgery, what do? We have an assistant trying to catch a bleeder with a mosquito or a tooth forceps, and then we apply diathermy. But when you don't have somebody, you do a cutting, you cut the skin and you cut the fat, and when it bleeds, you just place the electrode there and keep moving it over it only, and then the bleeder will stop. So, the longer you spend on the area, the more charring that you have and the more coagulation you have. the lesser the time you spend, the more the cutting and lesser charring. So, if you have a line of incision that you have to make and you are using a cutting and you are using it very fast, then you have a pure cutting. You do not have charring on either side. But then the same thing, you use the coagulation mode and then you do not move it fast, move it very slowly. Then you see the whole thing is becoming black, it is getting charred. The same cutting is happening in both, but then there is charring. So that is, that is what I meant by electrode speed and time on tissue. And then in laparoscopy, you have to remember we use carbon dioxide, and carbon dioxide retards electrosurgery effect. And so, supposing you are doing a laparoscopic surgery and then you did a surgery and immediately you have an open surgery, and then you put the pencil and then start, you see suddenly it works so much more than what was happening in your laparoscopy. Sometimes you may get so scared, what did I do? I used so much energy in the previous case, I might have burnt so many things inside. But your effect was retarded because carbon dioxide was inside the abdomen, and that is why you needed more energy. Now in open surgery you need less energy. So when you do open surgery you have to reduce the power settings and then start your surgery. Now let's talk about, we are not talking about electricity at all. We are talking about temperature. What does temperature do to body? See, we are using electrosurgery only to give a thermal effect on the tissue. Okay? So, how much thermal effect will cause what biological effect? We need to understand. So, supposing you have, and we also know that burns are seen as first degree burns on the day when a patient comes to you with burns, and after 3 or 4 days you see it as third degree burns. We have all seen that. So, there is something called an early effect and there is something called a delayed effect. So, early effect is what you see immediately, delayed effect can happen little later on. Means some amount of necrosis keeps on happening because of the heat that was applied earlier, and the effect of that necrosis is seen after a few days. So, if you apply something like hot water 34 to 44 degrees centigrade, you may not see anything immediately. Later on patient may have a little edema of the tissue. But when it becomes really hot, then also you may not see something, but later on there can be some necrosis. What does necrosis mean? Few cells have died. It is not that the whole tissue has died, it has not sloughed off. There is cell death, and that is called necrosis. But what is most important is this 50 to 80 degrees centigrade. In 50 to 80 degrees centigrade, you are seeing just a little bit of blanching that happens when you are operating. You have touched an intestine, there is a small whitish area that has happened over there. You have touched the ureter, there is a small whitish area that you can see on the ureter. It is not burnt, it is not sloughed off. But then after 4 to 7 days, you see sloughing of it. And that is the reason anybody comes to you between the 4th and 14th day after surgery with severe pain, you must think of thermal injury, diathermy has caused this, there is a perforation, intestinal perforation or a ureteric injury, and you have to rule that out. That is extremely important after laparoscopic surgery. Higher degrees, higher temperatures, you are not bothered only. Why you are not bothered? Not that it does not cause burns, but it has caused burns in front of your eyes only. So, so in the OT only you have seen, there is the whole tissue has shrunk and then it sloughs off later. There is a huge visible effect. But below 80 degrees, we saw only a little blanching of tissue, and that is what is more dangerous. Now we have something called endogenous burns, exogenous burns, and pseudo burns. Uh, Before I go to that, I would like to take you through a journey of. Now, I spoke to you about energy source, alternating current. Why does cutting happen? Why does coagulation happen? So it happens at the cellular level. So you need to understand that. So this is a nice animation that we've done to tell you about that. So now what happens when you apply alternating current? The electricity keeps going, coming, going, coming. So at one point of time there is an anode here and there is a cathode there, and the very next moment the cathode from there has come here and anode has moved that side. So when anode and cathode moves, anions and cations move. Cations are negative ions. Can you name some of them? Sure. And then chloride, sulfate, phosphate, bicarbonate, all these are negative ions. What are anions? Positive ions. Which are them? Sodium, potassium, magnesium, calcium. Yeah. So those are the positive ions. So these two keep moving on either side inside the cell. The cell is made up of majority what substance? Water. So there's a whole lot of water inside, and then you have these anions and cations moving to and fro, to and fro. So what is happening? Just watch this. They're beating each other. So it's getting hotter and hotter and hotter and hotter now. And it burst. The water became steam. And it became steam so fast, it didn't have time to escape, and it just expanded the cell so much, and then the cell wall broke and it went away. So what has happened? The cell vaporized. Okay? When you are doing cutting, you call it vaporization in electrosurgery. Why? Every cell you are touching is vaporizing, it's getting destroyed, and the cells on either side are falling apart. When you have a knife in your hand, you are cutting every cell into half. Here you are destroying every cell that you are touching. Okay, that is the microscopic difference in dissection. Okay, now let's talk about why cutting and why coagulation. So this is wait, the current that is flowing, it's a continuous current. I told you our machine can produce various waveforms. Supposing it produces a continuous waveform, alternating current only is coming, but it is a continuous waveform. When a continuous waveform is coming, continuously water is coming out. But then the voltage is not very high, need not be very high, it is less only. So it is continuously going. When this is coming, this will cause cutting or vaporization. And why does that happen? This positive and minus, it keeps changing, alternating current as it comes positive and minus. So continuously these cells of the anions and cations are moving. How many times? 5 lakh times, 5 lakh to 30 lakh times in a second. So fast they are moving and they are vibrating against each other. And so when that happens, they cause so much heat inside, so it bursts. Now why does it cause coagulation? Any? Huh? What happens? Now water is flowing in the pipe. Now this has stopped, it's come, it's stopped, it's come. So when you do this, the in the machine, the electricity machine is making it happen. It doesn't give a continuous current, it gives stops. Okay? When that happens, so this is the type of waveform. It stops, goes, stops, goes. So when it goes, see, it becomes slow, stops, and then again becomes fast, again stops. So when this type of effect happens, it is taking time to heat up. When it is taking time, whatever steam is coming is going out through the pores of the cell. So as the water is escaping, the cell is shrinking. Okay? So slowly the cell shrinks. That is what you see when you apply coagulation. You see the tissue is shrinking, whatever you are holding is shrinking. When you are using cutting, there is smoke and then it falls apart. Okay? I hope you could understand what I meant. So we have various types of burns. One is called endogenous, another is called exogenous, and another is called pseudo burns. I think I don't want to go into too much details. Okay. You want me to explain? I can explain. Endogenous burns is what is happening inside the body, and that is because you have touched something. You have a hook and then you were doing like that and then you went and hit something. So it touched something and then got burned. That is endogenous burns. Exogenous burns is where you've used alcohol. Now normally you should resist using too much alcohol. See, normally what we do, we use a lot of spirit, and then the spirit goes down and stays there. And many people don't put a proper bed sheet also, they are trying to save on money. So on the plastic sheet the patient is lying down. If you see in most of the government hospitals, that is what is happening. And then you have a bright light on your head. You say, I want more light, more light. And then you have a cheap cautery machine which is always sparking. So when you start using that, there's so much sparking happening. You come to the edge of the patient, there's so much spirit lying down there, the sparks will go and light the spirit. The spirit burns in a low flame. We have all seen this in a spirit lamp in our school days. So it burns in a low flame and you have a bright light on your head. So you don't see this fire. And at the end of the surgery, when you are moving the patient, you see there is a burn on the back. And you say, hey, this is that cautery plate there is something wrong, cautery machine is wrong. So this is exogenous burns. What is pseudo burns? It's not burns, it is a bed sore. How can bed sore happen in 2 hours? It happens in cardiac surgeries. You've given a cardioplegic, you caused the heart to stop and you have stopped blood circulation for some time. And then this patient is really heavy lying down on his back. And then there is absolutely no blood circulation for a few minutes on the back because of the thing. And that itself is enough to cause a big bed sore on the back. And when you are shifting the patient, you see this and you say, this is burns because of cautery plate not being applied properly. So this is called pseudo burns. Now active electrode burns. So active electrode burns can happen because of, as I said, different reasons. We also call it direct coupling. I told you the hook touches somewhere and then it can cause. And then you have a insulation failure. Somewhere the insulation is gone and that part is touching something, but your telescope you are not seeing it. So there you are getting a burn. So that is also an active electrode burn. Current diversions, alternative ground side burns, I told you drip stand, leggings, touching. Then you have couplings. These couplings are not cufflinks. They are very special for laparoscopic surgery only. You don't see it anywhere else. So let's go into them a little more in detail. Then you can have the dispersive electrode burn. What is dispersive electrode? Return plate or a patient plate. So you don't apply it properly, or you applied it but then you shifted the patient later and it has peeled off a little bit, or you put a some what is it, draw sheet or something, and then that has gone in between and lying there. So whenever it is not sticking 100%, a part of it is come out, then you can have a return electrode plate. Return electrode plates are of different materials, different conductivity, that is why you see them of different sizes. A metal plate, we were getting a metal plate and that was a very big one. And what were you supposed to do? You were supposed to wet a cloth and wrap it around it. And why were you supposed to do that? Conductivity, better conductivity. So because your back is not flat, you will have curves. So some parts may not be touching, and even if it is touching, it may not be a proper contact. So when water is like a liquid which is diffusing the electricity from one part to the rest of it. Now we had this black plate, the silicon plate which was coming with the LNT machine. Okay. What happened with the black plate? What was the difference between the metal plate and the black plate? The size was smaller than the metal plate was much bigger. The black plate became slightly small. It was like a rubber plate, if you all remember. Then now we have the blue plate, and in the blue plate you have a gel. It's a gelled plate. Okay. So when a gel is applied, like your electrodes, ECG electrodes, which is supposed to give maximum conductivity, that has become even smaller. These plates are much smaller. So that is the reason we have started coming down, because conductivity is better, but still there is a correction. You need not have all the 100% applied. Even 75% of the plate is touching, you will not have burns. If less than 75% is touching, only then you have conduction problems and you can have a burn at the patient plate. Okay. But that doesn't mean that you can compromise and say, oh, 80% is touching, let me go ahead. So that should not happen. And another complication, especially for surgeons and OT technicians and nurses and the anesthetists, is smoke inhalation in the operation theatre. Now direct and indirect coupling. So what is direct coupling? A direct coupling is in the upper thing where you have a instrument, there is an insulation failure. In B.E.S.T Institute and Research Center, Dr. Harinath has told you the whole of the metal part of the instrument should be seen when you are applying diathermy. So you are doing that, but then unfortunately you have a crack in the insulation here, and intestine goes and touches it, and then you have a burn. So that is called direct coupling. Indirect coupling happens when two instruments come very close to each other. You keep saying zoom in, zoom in, zoom in, zoom in. He's touching you and still you say zoom in. So what happens? The instrument is there and then you go and go so close, the energy goes there, and the telescope is touching an intestine, it goes there. So it is an indirect coupling. This is a direct coupling and this is an indirect coupling. Let me go back. So here there is a scissors where we want to burn this area, but when it is kept open so that we have precise burn, the other blade goes and touches here and that causes burn. So that is active electrode burn or direct coupling. there, it touched there. Okay. So now I'll just show you indirect coupling. Where is indirect coupling? So you have a telescope that is very close. No, this is the instrument that you are using, the trocar can. The instrument has come, you are using it, and it is touching here, and that is direct coupling. See, there is insulation failure there, it touches there, it is direct coupling. Okay. Now you have something called capacitive coupling. So capacitive coupling is even more complicated, as if those two couplings were not enough for you. So here there is a special thing that's happening. Every time, every time you move an instrument in and out, there is some amount of electricity in this, and that comes here and it goes to the instrument. From the instrument it is going to the abdominal wall. From the abdominal wall it goes around and reaches the patient plate, and it is going back to the machine. But then supposing you have a reducer here. So this is a plastic cannula and you have a metal reducer. So what happens, every time it is coming here, it is holding this, but it is not going to the abdominal wall because you have a plastic cannula outside. And this is called capacitance, means there is holding, the capacity is increasing, the electricity in the reducer, and suddenly the patient starts bucking, or there is a peristalsis and intestine comes and touches the reducer. There is a burst of energy that goes into that place, and then there is a burn in that place, and that is called capacitive coupling. So how do you prevent capacitive coupling? Yeah, so never ever use a combination of metal and plastic. If you are using, that's why when we use apple trocars, you see we use a rubber washer. So that is plastics and plastics. When you use a metal trocar, you have metal reducers. So that's how it should be, metal reducer and metal cannula, or plastic cannula and plastic reducer.
Monopolar can the insulation around the instrument cause?
Means you are talking about capacitive coupling? No, capacitive it doesn't. Means direct coupling because of insulation failure, I showed you, that happens.
In Hassan technique, sir, we are using a plastic cone around.
Plastic?
There is a
Cone. Yeah, you are not using any current there. No, you are putting a telescope there. You are using surgery, you are performing surgery in other places. Now this is the patient plate I was telling you, it comes off and only a small part is touching. So there is again focus of all the energy that comes to one particular point and can cause a patient plate burns. Now let's come to other energy sources. That's about diathermy. Now you've heard about argon beam coagulator, right? So this is an add-on to a diathermy machine. You add on one more machine, and then this argon beam coagulator is a spray. So there is a spray of argon gas, like a spray coagulation, and that causes fulguration. It causes superficial coagulation. So you have a liver bed which is all burning, oozing, or you have endometriosis. There are a lot of red spots everywhere. Or you've done a pelvic surgery and then oozing on the pelvic surface. So then you can use an argon beam. Allows even efficient and broad application of coagulation current on tissues, ideal for obtaining hemostasis along the cut surface of the liver following hepatic resections. So let's see how it works. See, this is a spray. You are just spraying it. You are on the urinary bladder, but you are spraying as a superficial coagulation. It does not enter the bladder. Okay, you are on the UV fold. There is a lot of endometriosis there, and you can just use it safely. Okay, give it to a child. You see what it can do. Now cryotherapy. So cryo we've been using. Uh, we don't use it like in general surgery. So I don't want to spend too much time talking about cryosurgery. We use it to perform piles operations. We use it for chronic cervicitis. Basically, this is a surgery where you are cooling the tissues, you are freezing tissues. So the cells freeze, and because it freezes so to such lower temperatures, the cells die, and they are all dead. Slowly they necrose, they fall off, they slough out, and then they fall off in the next 2 to 3 weeks. But then in cryosurgery, the disadvantage is you cannot see to what extent. In organ beam, you could see which is the dead and which is the alive. Here you cannot see. So you go by the rule of the thumb. You say in chronic cervicitis, I want 2 to 3 millimeters of coagulation or 5 millimeters, whatever it is. So that will happen when I hold this cryo for 5 minutes. So you go by the clock, you don't go by your looks. The same thing with piles. We either hold it for 1 minute, we hold it for 1.5 minutes. So based on what you are coagulating, this is how I do it. I am supposed to do it for 1 minute. You can do it on liver tumors. Again, you go by time. You go touch it there and use it. So you can either use nitrous oxide or you can use carbon dioxide. Both liquid nitrous oxide and liquid carbon dioxide, both are less than minus 200 degrees centigrade. And they get into a probe, and the probe touches the tissue and transfers that temperature to the tissue and causes cryocoagulation or cryonecrosis of the cells. So this is called cold shock injury. Reduction in cell volume by osmotic dehydration, denaturation of vital cellular enzymes, and perforation of cell membranes by intracellular ice crystals, destruction of tumor microvasculature. Now the same type, we also have something called infrared coagulator. Even this goes through a wand, like you have like a long rod, and on that you have a crystal, and through the crystal there is the light that is produced, that is the infrared coagulation is done. It is usually, again, for hemorrhoids we use it very commonly. It works very well. So you just have to go and use it. You have to touch the piles with that infrared wand, like a magic wand. It will just ring that piles. So that is a but yeah, it does not have too many uses, so you cannot use it for many other things. Now ultrasonic dissector, this is something that we use in cytoreductive surgery. I've applied, I've put a wrong video here. Actually this is harmonic scalpels, ultrasonic scalpels. This is an ultrasonic scalpel being used on tissues. This is the intestine and the mesentery, and we are cutting the mesentery. The mesenteric vessels are being coagulated and cut. There is not a single drop of blood in spite of cutting all this, and you will never know because you are sealing off the tissue on either side. Even if you made a small cut in the intestine, you will not realize it because both of them get stuck to each other. And that is the reason why you should not go very close to vital structures like a common bile duct or a cystic duct. If you have done it, it will seal off. You will not know that you have gone through a duct. After some time it may necrose and then it may open up and then you may have a bile leak. So this is this thing. But ultrasonic dissector is like a probe. You just hold it on liver tissue. When you hold it on liver tissue, it will vibrate and it will remove all the liver cells. So what is left out is only the bile ducts, the hepatic vein branches, the hepatic artery branches, portal vein branches. So the vessels and the ducts are left and the liver cells go away. So you can see them, you can apply clips, you can tie them, ligate them, do all that. So wherever you want to do a liver resection, on that you just do a pass the dissector, touch it there, you scatter off the cells and then deal with the structures which are dangerous and you have to ligate them. So ultrasonic knife is what I was talking to you about. This is the harmonic scalpel. Harmonic scalpel is a name of the ultrasonic knife that is manufactured by Ethicon Endosurgery company. So there are so many Sonosurge, so many different names for this ultrasonic knife. So the generic name is ultrasonic knife. What it does, it has a probe, it has a metal probe, and this metal probe is a straight one. It is made of piezoelectrical material like your ultrasound machine probe. But in ultrasound, supposing you are doing an ultrasound of the abdomen, you have crystals which vibrate at 3.5 megahertz. Can you translate that? .5 megahertz is 35 lakh hertz. Okay. Now this is 55,500, 55.5 kilohertz. Okay. If you are doing a superficial ultrasound scan, you have a 10 megahertz. So 10 megahertz is what? 10 million. That is 1 crore. 1 crore hertz is the amount of vibration that the ultrasound probe is doing to get you an image of a soft tissue. But here the same vibration is used at only 55,500. And what does that do? It rubs against the tissue. When it rubs so hard, it causes friction, and the friction causes heat, and the heat causes protein coagulation, and the protein coagulation causes desiccation, whatever, vaporization, all those things. So here normally you have a temperature of less than 100 degrees centigrade. You don't have more than 100 degrees centigrade. What does that mean? It means, oh, I didn't tell you about the amount of temperature that is created by diathermy. How much? In a bipolar diathermy, if you are catching a tissue, what is the temperature the tissue can go to? It can go to 200 to 300 degrees centigrade. In a harmonic scalpel, it can go up to 80 to 100 degrees centigrade. Which is safer? How is it safer? It's higher heater. Hot.
If it causes any damage, we won't be able to recognize it immediately in the surgeries.
Which one?
In harmonic. Even the complication profile, bipolar is relatively safer.
That is when I said when you're. No.
The blades are
See, there are. The reason you are giving is not right. You are telling the right answer. See, when you are supposing you are catching a duct, the duct can necrose and open up. A vessel, an artery or a vein, you are catching with a harmonic scalpel. After some time, there is nothing called delayed burns. The blood is clotted. Okay, the blood vessels will never open. But there is something called lateral thermal effect. When you are on a uterine artery, if you are very close to the ureter will get burnt. So you must be at least 1 centimeter away when you are using a bipolar. You can be just 1 millimeter away when you are using a harmonic. But after you finish it, you take out, your instrument is cold. Bipolar instrument is very cold. Tissue has become hot because current has gone inside, the cells have rubbed each other and they have become hot. You are not sending heat. Here you have, this instrument is rubbing on the tissue, and so when the tissue is becoming hot, the instrument also is becoming hot. So this hot instrument, you touch something, next you want to retract and then again go, you are causing burn there. So harmonic scalpel is a very dangerous instrument. It's a very good instrument, but at the same time it's hot. You have a hot instrument in your hand, please remember it. Whatever you touch, you have to be very careful. In bipolar, monopolar, you can touch anything as long as you are not pressing the foot switch. Okay. So here you can do both cutting and coagulation like in monopolar. There is no electrical energy transferred to patients. There is no lateral spread of thermal injury. So these are all advantages of an ultrasonic knife. Now, variety of vessel sealing devices. You can seal a vessel with a monopolar, you can seal it with bipolar, you can seal it with ligature, which is a equipment manufactured by Valley Lab, which has now become Medtronics. You can seal it with N-seal, which was earlier manufactured by a company as SurgeRx, which is now bought over by Ethicon. It can be done by Cayman, Gyrus, ultrasonic scalpel, Bicission, Thunderbeat. So different companies have different names and slight difference in their functions. So let's know a little bit of everything. Ligature can seal vessels of 7 millimeters in size. It is a bipolar modified. You are applying compression and bipolar intermittently, like a coagulation current. In monopolar coagulation, how it is, like that in bipolar you make it like intermittent coagulation. With compression it becomes ligature. So up to 7 millimeter vessels, that is uterine vessels, splenic artery, renal artery, all that, adrenal artery, these medium sized arteries can be sealed off using ligature. So, wait, I don't know. So you see how nicely it is. There is no lateral thermal effect at all, and it is so fast. The gastroepiploic artery branches are all being cut, and you are going very close to the stomach, but you can't see any burn there. You can't see any burn on either side. It's almost like a harmonic scalpel, or sometimes even better. N-seal is the same thing, little different. They have thermal sensors on them, and it is an intelligent machine. It can manage stopping the energy based on the temperature that the tissue is getting heated to. Cayman is again a different instrument, which is very long jaw, 5 centimeters long it is. Each time you catch 5 centimeters you can coagulate and cut. So that is Cayman. So they use different terminologies, they use different sentences to tell you it is doing some nonsense, but it is all doing exactly the same. Now this is Gyrus. Gyrus is a bipolar electrosurgical device again. In each one they have slightly changed the temperature settings, they have changed the electricity settings, they have changed the size and shape of the instrument slightly, and then the type of cutting is also different in different instruments. You have a knife which looks different in different instruments, and the probes are of different sizes and shapes. So harmonic, we saw about harmonic. Up to 5 millimeter vessels can be done. Now thunderbeat is another cocktail. Here, instead of after sealing, you cut with a knife in Cayman, gyrus, enseal, ligashore. But in thunderbeat, you are using ultrasonic knife to cut the tissue. You are using bipolar to coagulate, to seal the vessel, and then it cuts using a harmonic scalpel in layman's terms. It's a very good instrument. I've used it for oncological surgeries and it works very well on big vessels. See here you can see big vessels, that is the aorta behind, and then you are going just above the aorta, that must be the inferior mesenteric artery which is being sealed off and cut. So you have something called bicision. So bicision is similar to a bipolar but much wider and bigger instrument. And here again there is a knife inside and it's a wide loop. So there is a little bigger amount of coagulation of tissues when you use a bicision. It is also called a tripolar instrument. Now there is a lot of work done using all different things. Gyrus, ligashore, enseal, everything, and each one has different types of energy sources. I don't know why it has gone. Then you have lasers. Lasers you have Nd:YAG, argon, HOYAG, KTP and diode lasers along with carbon dioxide. So carbon dioxide is a non-contact, it is like a beam, laser beam which goes and cuts. But then when you are using that, after cutting something it will go and cut something else. So what you should do is you must keep an instrument behind it. You have a broad ligament, you have a round ligament, or behind it you keep a 5 mm instrument and cut it exactly on that. Then it cuts beautifully without causing any bleeding. Now what is the advantage of using lasers? There is no edema of tissue and so they don't have pain. So whether you cut piles, you cut any tissues with laser, the beauty of it is it does not cause pain. So I started talking about harmonic, ligashore, gyrus and enseal. The amount of temperature they can cause, the amount of pressure each one applies. The time it takes to seal, ligashore takes the least amount, and smoke also is least in harmonic scalpel when compared to the others. This is the lateral injury, how much lateral injury it causes. This is the burst pressure. Burst pressure is when a vessel, you push blood through that after it is sealed and cut. How much pressure you need for it to open up and start bleeding. So normally our BP can go up to 200, it won't go beyond that. So most of them, harmonic is only 204, these are all more, it's between 250 and 400. So you're sure that they will not open up later on. So these are lasers, I told you. The acronym of laser is light amplification by simulated emission of radiation. Okay, and the properties are, it is coherent, it is monochromaticity and collimation. And these are the lasers I talked to. Light, it's all light. Yeah, different things are used. Argon gas is used, carbon dioxide gas is used, diode rod is used. So through that the light will come and then pass. KTP lasers. So they all have their own advantages, but the disadvantage is it can only penetrate up to 200 microns. So they cannot coagulate vessels. If you have vessels, they will bleed. You can only cut tissues using lasers. If it is diode laser, things like that, it can, contact lasers can cause coagulation to some extent. HOYAG and diode can do that.
So combination of laser plus bipolar should.
Right hand laser, left hand bipolar. That's why God has given you two hands.
For retraction
Retraction, your assistant will retract. Okay, any questions? This is too much indigestion. No?
Sir, while using the direct therapy, the pacemaker was a contraindication. So
Yeah, yeah.
what about if the person has a metal, like if they have some
No, no, nothing happens. It will not go there. See, if the metal is protruding out of the body and touching something outside, then it can come in and then come out. So if it is inside the body, nothing happens. The pacemaker, we are bothered because electromagnetic induction means the rate of it can change. There can be fibrillation with the pacemaker, and it's not that you cannot use pacemakers. You can use it at even in monopolar. You can have very low voltage, and you can apply the patient plate close to the operative field. Supposing I am doing a thyroid, then I keep the patient plate here only. I am operating on the right thigh. I can keep the patient plate in the right gluteal region or just behind the right thigh. So it does not have to cross the heart. Supposing I am doing a thyroid surgery or a parotid surgery and I have the patient plate in the left leg or the left thigh, then it is a problem. But as a general rule, try to not to use it. But today what has happened, you can put off the pacemakers. So every time we have a patient with pacemaker, we still use monopolar diathermy, but just before surgery, the technician comes to the operation theatre, puts off the pacemaker, because here the heart rate can be regulated and observed by the anesthesiologist during surgery. So in the surgery we use whatever we want. After the surgery, immediately call the technician and ask him to put on the pacemaker.
So in indirect coupling, the part which is not covered by sheath should not touch other instruments.
No. See, when you have a metal part of the instrument, you supposing you are using a Maryland dissector and then you are coagulating something. Now you want to zoom in very closely. So the instrument, the telescope comes very close to your Maryland dissector. What we have seen with spray coagulation is electricity does not need contact for spread. It can jump. So if it is just half a centimeter or less, then it can jump to your instrument and then need not touch also. It can jump to your instrument, and through the instrument, if anything else is touching that instrument, it can pass to that organ. So it need not be as long as the metal is touching. So a telescope is full of metal. It's a metal tube. Even other instruments, it need not be telescope. You have another grasper in your hand that has come very close to your Maryland dissector, which is being used with diathermy. Then the metal part of the grasper, till there if something is touching it, it can cause burns. Beyond that, there is insulation, nothing will happen.
So around half centimeter.
Half a centimeter to 1 centimeter. So always remember, diathermy happens as a non-contact mode. When you have three effects, vaporization, fulguration and desiccation, two of the effects are non-contact. That itself tells you that it can jump, electricity can jump. You don't have to be in contact. And spray coagulation is a standard way that you use it for fulguration. Organ beam you are using a lot of things during surgery like a liver bed, ooze and things like that.
So when we are holding, we have to zoom in, but when we are coagulating, camera should come.
Yes, exactly. When you want to see a very precise holding of a blood vessel, you go very close and show, but after grasping it, you zoom out the telescope and then apply diathermy. Okay?
So monopolar is a non-conducting is there, sir. While you are using a trocar, metal trocar, then coupling happens here because plastic can.
Plastic will never, it is insulation.
The insulation is there and trocar is metal, sir. So there is a combination with plastic.
No. See, in capacitance, it is only the reducer that holds the electrical energy. The instrument is not holding energy. So from the, when you are moving the instrument in and out of the reducer, a little of the electrical energy on the instrument, tip of the instrument will jump into the reducer and will hold on to the reducer if the reducer is insulated around it, means you have a plastic cannula around it. That's why they say don't use hybrid systems. You use all metal or all plastic. Okay? Fine. Thank you.
Thank you, sir.
Yeah.
When you are cutting the wards in the last stage of ALH, we use madam use spatula. There is no risk of injury to ureters. Will it not?
If the ureter is being touched, there is no, as long as you are away from the ureter. See, ureter will get injured only if the spatula touches the ureter or if the heat in the area where you are applying the diathermy is so high that it is transferred to the ureter, which is almost very close to that area. So normally in diathermy, whether it is monopolar or bipolar, the temperature can go up to 200 to 300 degrees centigrade. Okay, so you must always aim to have a margin of 1 centimeter for any critical organ which should not get burnt. Ureter should be 1 centimeter away from your spatula.